Hi, Anita Schneider here from Bang Albino Communications. I'm at ASCO 2012. Today is Monday, June 4th, and I've got Dr. Ron Burkes here from Sinai Hospital. He's going to talk to us a little bit about yesterday's lung education session and also the first oral lung session from today.
Before I start, I just want to mention a couple of things that were presented at the educational session yesterday afternoon, looking at the tyrosine kinase inhibitors, as well as ALK inhibitors, and looking at resistance to these agents. And a couple of interesting points were made. First of all, that patients who have an EGFR mutation and are receiving an oral tyrosine kinase inhibitor will often have a flare of the disease when that drug is discontinued. And it was commented on that in patients certainly who have a slow progression of their disease, one should not discontinue the oral tyrosine kinase inhibitor because of that risk. The other interesting thing that came out of that educational session was the fact that there appears to be from sequential biopsies, that it was presented by Dr. Sequest, that patients who have sequential biopsies seem to develop resistance mutations, and that when they stop the tyrosine kinase inhibitor, these mutations may disappear, and then patients can re-respond when they restart the tyrosine kinase inhibitor. So these are some interesting bits of information that are slowly coming out. We still have a long way to go to try and determine how best to manage patients who develop mutations, whether we still continue the tyrosine kinase inhibitor by itself, whether we continue the tyrosine kinase inhibitor and add chemotherapy, or whether we just add chemotherapy immediately. In any event, we still have a long way to go to figure out how to manage these patients in the best way. So let's move on to the oral presentation this morning. This dealt really in three groups, with three subgroups of presentations. The first dealt with consolidation therapy for patients with locally advanced stage 3A and 3B non-small cell lung cancer. The second group dealt with small cell lung cancer, and the third group of presentations dealt with some data on genomics and molecular biology. So with respect to consolidation therapy, a couple of interesting trials were presented. Firstly, the Japanese presented a meta-analysis looking at 41 trials for stage 3A and 3B non-small cell lung cancer. Now this was a pooled analysis. They did not have data on 3 and 5 year survival, nor did they have data on the specific regimens that were used, but they did show median overall survival and looked at the role of consolidation therapy versus no consolidation therapy, and could not demonstrate in this meta-analysis any benefit to the use of consolidation therapy. The median survival in the arm without consolidation was 18.1 months versus 18.5 months in those patients who had consolidation therapy. Hazard ratio was 0.98 and not statistically significantly different. However, as mentioned, no data on 5 years survival and no data on which chemotherapy regimens were utilized. The second trial that dealt with consolidation therapy was the GILT trial. This was a German study that looked at oral vinorelbine plus cisplatin, with concurrent radiation therapy, followed either by consolidation chemotherapy with vinorelbine given orally with cisplatin versus best supportive care. And this trial did not demonstrate any benefit in progression-free survival or median survival. They did demonstrate, however, in patients who had stable disease, there was an improvement in progression-free survival, and there was an improvement in the disease control rate with consolidation therapy, but as mentioned, no benefit in overall survival. They had no data on what the patterns of failure were. Specifically, was there reduction in systemic relapses in these patients who potentially got the consolidation arm versus those who did not. With respect to the small cell lung cancer group of trials, the Japanese presented their study of amrubicin cisplatin versus their standard of care, which is irinotecan cisplatin. This is not our standard of care in North America. Studies in North America have not shown that irinotecan is better than etoposide cisplatin. However, in the Japanese, that is their standard of care. They did not demonstrate any difference in outcome with amrubicin versus irinotecan. In fact, there was a significant increase in febrile neutropenia of 26% versus 10% with amrubicin that resulted in the necessity to lower the dose of amrubicin. So there was no benefit in outcome with amrubicin. Irinotecan still remains the standard of care in Japan. The other trial of interest with small cell lung cancer was a second-line trial after platinum-based failure in extensive disease small cell lung cancer. It's a randomized trial of topotecan plus or minus aflibercept, which has anti-angiogenic properties. This trial did meet its endpoint in terms of 3-month progression-free survival, but it did not result in any overall survival benefit. The response rate was only 2%. However, it brought up an issue by the discussant, which is something we've known for a long time with anti-angiogenic agents, and that is our ability to use RECIST criteria doesn't quite apply to patients receiving these agents, and that despite low response rates, there still may be benefit with these drugs, and that other methods of assessing response are needed when patients are receiving anti-angiogenic agents. Finally, in the last group of studies looking at genomics and molecular biology, I just will comment on one study, and that was the LACE bioanalysis looking at KRAS mutations in non-small cell lung cancer. This was presented by Dr. Francis Shepard. The LACE bioanalysis is a pooled analysis of the 4 randomized adjuvant trials in recent years that have shown the benefit of adjuvant chemotherapy. This looked at 1,543 patients that were pooled. 19% or 300 had KRAS mutations, and the remainder, 1,243, were wild-type KRAS. These patients, this study was looking at the prognostic and predictive effects of KRAS, and in fact, they were not able to demonstrate a prognostic effect or a predictive effect of KRAS whatsoever. Interestingly enough, however, they did show that patients who had KRAS mutations in codon 13, which represented a very small subset of patients, only 24, actually had a detrimental effect when they received adjuvant chemotherapy. So this needs to be looked at in more detail with more patients, but certainly is suggestive of something that may be important, for this may be a population who should not receive adjuvant chemotherapy, but as I say, at this point in time, the numbers are too small. In addition to that, Dr. Shepard, they looked at the role of KRAS in second primaries. There were 86 patients, or 6%, who developed second primaries. The observational arm had a 3-fold increase in second primaries compared to the chemotherapy arm. But interestingly enough, patients with KRAS mutations who received chemotherapy actually had a reduction in second primaries or second cancers. There was no explanation for this that could be given, and there's really very little that can be hypothesized as to why this should occur. So the bottom line was that KRAS mutation does not have a prognostic or a predictive effect. Potentially codon 13 mutations may have a detrimental effect, but at this moment overall there is no predictive effect of KRAS mutations in patients receiving adjuvant chemotherapy.